Good afternoon, my name is Linxin and I'm a Senior Research Fellow at the Wolfson Center for Prevention of Stroke and Dementia at Oxford University. It's my great pleasure to have Dr. Falcone and Dr. Szejko today to tell us a bit more about their very exciting study on epigenetic age and stroke. Dr. Falcone is an Associate Professor of Neurology and Director of Clinical Research in Neurocritical Care at the Yale Medical School. Dr. Szejko is a neurologist who was trained in Poland and is currently doing her postdoctoral fellowship at Yale. Welcome both and congratulations on this very interesting study that is going to be presented at ESOC 2022. So first of all, can you tell us a bit more about what epigenetic clocks are?
Yes, thank you for having us. It's great to be here and it's great to be presenting at ESOC. Epigenetic clocks are related to the concept of epigenetic age and biological age. They are a tool to measure biological age and epigenomic age. And the intuition behind these concepts is that sometimes what we see as chronological age, the numeric age, the age that we assign to a patient, is not what we really see on the ground, what we really see from a biological perspective. So biological age and epigenetic age is a type of biological age, is a concept that tries to reflect the age of a person based on their physiology and their biology. So these biological clocks and these epigenomic clocks are trying to capture, to measure this idea that the age based on physiology may be different from the numeric age, from the chronological age. And this is something that we see in clinical practice all the time. A patient that we see with an acute stroke in the ED, maybe, for example, 65 years of age. But when we go through the chart, when we look at the labs, when we examine the patient, we oftentimes say things like, this patient looks older or looks younger than their age. So clocks, epigenetic clocks and biological clocks are tools that we use to capture this idea of age based on biological status.
Thank you. And so what do we know about epigenetic clocks and cardiovascular disease before your study?
Yes, epigenetic clocks and epigenomic clocks are, being widely studied in a number of fields. And we do know, and these are sort of relatively recent studies, that epigenetic clocks and epigenomic clocks are related to the risk of cardiovascular disease when you consider cardiovascular disease broadly. And again, it's not so much the clock itself, is the age, the biological age, the epigenomic age that is reflected by the clock. So far what is known is that, as expected, and again, if you follow the intuition of biological clocks reflecting the age based on the biology of the person, then it makes sense that by the same argument that chronological age is associated with increased risk of cardiovascular disease broadly considered, then biological age, or epigenomic age, measured via an epigenomic clock, it's also related to cardiovascular disease broadly considered. One important point is that in all these studies, we are adjusting for chronological age. So what we see is that even after accounting for the chronological age of a subject or a person, then these clocks, these biological clocks, these epigenetic clocks are associated with the risk of cardiovascular disease. One important point is that even though this question has been extensively studied in cardiovascular disease broadly considered, the amount of data and the number of studies on cerebrovascular disease, on stroke, and on brain health, which is sort of a downstream consequence of long-standing cerebrovascular disease and many other processes, has been much less studied. So I think that the novelty, the reason why these results are important, is that they consider an application of something that is being actively explored in cardiovascular disease broadly considered, and we bring this question to the realm of stroke and cerebrovascular disease.
Yes, absolutely. So can you tell us a bit more about the design of your study and what have you found?
Yes, so our study, as many other studies that are done by our group, was conducted on big data samples. So we used data from the health and retirement study, which was conducted and is still conducted at the University of Michigan. We used also the information that was collected regarding the epigenetic aging of the participants. Then we checked whether there is an influence between epigenetic aging that is defined by epigenetic clocks, as mentioned by Guido, and the risk of stroke, and vice versa. So whether the people who experience stroke, they have higher epigenetic age and they age quicker. So we found that yes, there is a relationship between stroke and epigenetic aging, and also that people who are epigenetically older, they develop stroke, they have high risk to develop stroke. And as mentioned by Guido, very important was also that we also included in our analysis sex, gender, and chronological age. So that is sort of we excluded these factors, and that's why this is promising and very important, seems to be a very promising and important biomarker.
Yes, very important finding. So do we know if, or have you actually looked at vascular risk factors as well? Do they affect epigenetic clock as well? And is there any interaction, for example, with age, sex, and vascular risk factor?
Yes, so of course, previous studies, there are a lot of previous studies that have demonstrated that a number of vascular risk factors, such as, for example, hypertension, diabetes, arteriosclerosis, they influence epigenetic aging. So yes, so in our analysis, as I mentioned, we did include this in the analysis, but we haven't done yet the interaction analysis. But this is, of course, next step to go, because it would be extremely interesting to see, for example, whether there is the influence of gender in the interaction analysis. Or, for example, race and ethnicity, which is also big interest of our group. As just today, when I checked PubMed, just recently, there have been some studies exploring this topic. So that, for example, epigenetic aging and the influence, the interaction analysis with race and ethnicity. So this is for future of our analysis. Yes.
And a couple of follow-up comments. One is that we see that when we throw vascular risk factors into our models, the signal, the strength of the signal, the strength of the association between the epigenomic clocks and the risk of stroke decreases a bit. So this could be confounding, but it could also be mediation, right? And that poses a very interesting scientific question that, perhaps we should not be adjusting for the cardiovascular risk factors. Perhaps these risk factors are the ones that accelerate the epigenomic age, and in turn, that leads to an increased risk of stroke. So that's sort of follow-up comment number one. And then follow-up comment number two is that the reason we didn't pursue interaction analysis is that, these are complex and expensive studies, and that involve thousands of people. And in these large sample sizes, we still get not so great number of strokes. So we have 342 strokes. So we know from the get-go that we'll be underpowered. So this is why, to appropriately pursue interaction analysis, we would like to have more data, as it's usually the case for science. We always want more data.
Yes, usually, and it would be it would increase your power as well. And for such an emerging field, it would be very important to do the planned analysis that you suggested. So you've studied a range of epigenetic clocks. So do you think the similarity or difference among them with regards to their association with stroke tell us something about potential mechanisms or potential targets for future treatments, for example?
Yes, so as mentioned by Guido, epigenetic clocks generally they are built, of course, as the name says, take on the methylation data, yes, using methylation data. But the majority of these clocks, they actually use the combination of epigenetic data, methylation data, and some clinical variables that our clinicians know, for example, creatinine and CRP. And then they use some complex algorithms to build epigenetic clock for each individual. So actually, it was very interesting that that two clocks that demonstrated the strongest signal they were actually built only using the methylation data. So maybe this is some potential mechanism that is behind this. Yes, this was one of the most interesting findings also of our study.
Thank you. So final question from me, what will be our next step from here, you think?
Yes, it's an interesting question, and it's a complex question. This can go in a number of different routes. As we were saying before, one important follow-up step or next step is to partner with other institutions and with our groups who are interested in this topic to one, increase our sample size, but also be able to pursue a more sophisticated version of this question. As Natalia was mentioning before, we're very interested in seeing if there is effect modification by race ethnicity. We're also very interested in the contribution of socioeconomic status and overall sort of a contribution of social factors. So this trial of epigenetic age, race ethnicity, and social factors we think is very promising. And our hypothesis, and it's not ours, I think that many people will agree, is that there is a synergistic effect. There are biological components, race ethnic components, and socioeconomic components that all sort of come together to create a significant increase in risk. So that's, I think, follow-up question number one. Follow-up question number two, which is one that we are very excited about, is that, and we're already working on it, is that most likely there is an interaction or there is an interplay between epigenomics and genomics. A bunch of the work that we do is focused on genetic variation, not epigenetic variation. And we're very interested in looking at the joint contribution of genetics and epigenetics. So that's sort of in line with this idea that we are adding more and more layers of data. So we include, for example, genomic data, transcript dubbing data, proteomic data, epigenetic data, to sort of try to refine the biology behind these associations. And then follow-up question number three, which we are very interested, but we have not sort of acted on, is the clinical application, right? How can we bring this to our patients? I think we're still a bit far away from that one, but I can tell you one low-hanging fruit that I think could be exploited in the relatively short term is that age, it's a very important variable when we consider treatments and randomization to clinical trials, and I'm talking about chronological age. By the same token, if we all come to the conclusion and we all agree that biological age provides additional information on top of chronological age, you can see that in the not distant future, epigenetic age as a way of measuring biological age could be used, for example, to select people for clinical trials or to change the indication of a drug. And this sort of, it's very clear when you are sort of designing and implementing a clinical trial that is focused on middle-aged persons. Sometimes we use thresholds like 75 years of age, 85 years of age. And we know that there are people who are chronologically older than this that could qualify for these trials. And we know that there are people who meet these criteria, but when you look at the biology, when you look at the renal function, at the liver function, at the overall inflammatory status, at the overall burden of vascular risk factors, they're much older, and we know that they will not sort of fit that particular trial very well. So I think that could be a very practical application, assuming that we confirm all these findings in different studies.
Thank you very much, Dr. Falcone and Dr. Szejko, for sharing with us your excellent study, and congratulations again. I look forward to seeing you all at ESOC 2022 in Lyon in May.